We have the largest number of registrants to any event in the history of our industry association. So thank you all for registering and joining us and making it a special occasion in that regard. I'm also pleased to share with you that we have a number of guests from the Federal Department of Health joining us this morning. So to those of you, I know Gary Lum, you've already made your presence known. Welcome, and thank you also for joining us. Now, before we get into proceedings, and in the spirit of reconciliation, the Board of Directors, employees, and members of Pathology Technology Australia acknowledge the traditional custodians of country throughout Australia and their connections to land, sea, and community. We pay our respect to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. So as your host this morning, it's incumbent on me to explain to you the order of proceedings, of which we have two parts. And the first, we'll be joined by three fantastic speakers. You see them on screen right now, each here to share with us their unique perspectives and insights on our AGM theme, which is the role of testing technology in Australia's response to COVID-19. And then that will be followed by the AGM proper, and we aim to finish proceedings around 9:30 this morning, so you can all get on with your day. Now, we do have a lot to get through, so I don't want to be simply rushing, but we need to now introduce our three speakers. And as I mentioned, we have three wonderful speakers this morning who've graciously given up their time to share with us their learned opinions. Our first speaker will be Professor Vitaly Sinchenko, who is the Director at the Centre for Infectious Diseases and Microbiology, Public Health at University of Sydney, and is also Staff Specialist with New South Wales Health at ICPMR Westmead. Professor Sinchenko, welcome, and thank you for joining us. Wave and be recognised.
Thank you. Good morning, everyone. I'll start sharing my screen.
Just a moment, Vitaly. Just a second. Just let me introduce the rest of our speakers, and I'll pass the floor over to you. Professor Sinchenko will be joined by Professor Michael Wallach from the School of Life Sciences at the University of Technology, Sydney, and he's also the inaugural Regional Director of Spark Oceania and Spark Sydney. Professor Wallach, wave, be recognised. Thank you and welcome. And last but certainly not least, Professor probably doesn't need an introduction, but we have Professor Mary Louise McLaws, who is an epidemiologist and an advisor to the World Health Organization, amongst many other things. Professor McLaws, pleasure to have you with us this morning.
Thank you for asking me to join you.
So the way it's going to work is all of our speakers have been given up to 10 minutes to present their perspectives on the role of testing technologies in Australia's response to COVID-19. This will then be followed by a Q&A session, a 15-minute Q&A session. So we encourage you to type your questions into the Q&A box in your Zoom window. We also have a voting system in there. We do only have 15 minutes, so we're going to use the voting system as a means of determining which questions to ask at the end. If there are many questions, we'll then work with our speakers afterwards to see how we can get a lot of those answered for you. For those who haven't been able to join us this morning, not a problem. Our event this morning is being recorded and will be posted onto the PTA website later today. Okay. So now, Professor Sinchenko, please share your screen with us. And once you've done that, you have the floor.
Can you see my screen?
We can see it, yes. It's not in presentation mode, however.
Okay, thank you. Yeah, I'm trying to move it. Okay, terrific. Good morning, everyone, and my thanks to organizers for this opportunity to present really practitioners' view on genomic surveillance of coronavirus and the role of this surveillance in COVID-19 control in a very short period of time. I'm a clinical microbiologist based at Westmead Hospital, so I will be talking about very practical aspects of this genomic surveillance. And I would like to start with acknowledgement of Eddie Holmes' role in discovery of this virus and most importantly in sharing full genome sequence of this virus early on. So this is a tweet from January, bringing attention of the international community to this genome availability. This is a relatively small RNA virus, and Eddie is one of the international leaders in evolutionary biology of RNA viruses, and genome was really high quality, enabling laboratories around the globe to develop diagnostic tests, PCR-based tests, first of all, to identify with high accuracy this pathogen in clinical samples, and enabling, so to speak, very powerful glasses for everyone to have to recognize a disease, an infection. And what happened afterwards has been really remarkable. In a short period of time, within several months, hundreds of genomes have been uploaded to GZAID. This is a database developed initially for human and avian influenza virus research and genome sharing, and has been applied to COVID-19 data sharing internationally. And we contributed to that database in Australia in a big way as well. And you can see exponential growth in number of genomes sequenced from January to several hundred, and then over the 100,000 genomes now. And these genomes are available to everyone for analysis, and several secondary databases and visualization tools have been developed to help clinicians, to help researchers to analyze these genomes. Next strain is one example, and map from a next strain shows sequenced in Australia is really outstanding. If we move to New South Wales, and I'll be talking about New South Wales for the rest of my presentation, it's really activities in two centres, and microbial genomics laboratory at CIDM, at ICPMR Westmead, where I work, and the labs that I supervise, has been paramount in mounting genomics guided public health investigations in New South Wales. It's a team that combines expertise in microbiology, genomics, epidemiology, and informatics. And they're all much younger than me, smarter, and very, very motivated. What has been interesting for me to watch, that we've gradually converted from using NextSeq, which has been our working horse in a lab for several years, because we've been sequencing large numbers of different bacteria with epidemic potential, and we continue to do so. Then to MiniSeq, and now using iSeq for COVID-19 work, largely because NextSeq is just too big. And weekly runs are not sufficient, so we're switching from machines that gives you, 200 gigs of data in one run to machine with a yield around 1 gig, from sequencing 100 to 200 bacterial genomes in one run to sequencing 5, 10, 20 viral genomes in one run, but doing it almost on a daily basis instead of weekly basis. And genome analysis puts genomes into a category of unique or distinct genomes, or clustered genomes, where we define genomic clusters with as isolates with less than 2 SNPs between them. And this fish plot, developed by Jenny Dropper, one of our bioinformaticians in our laboratory, shows the dynamics of clusters in New South Wales. You can see that in March, April, at the first wave, when we had a lot of cases, we have multiple clusters. So each color represents different cluster, and each cluster originated from independent importation of a case from other country with circulation starting in New South Wales. Lockdown and strict public health measures allowed us to squeeze this outbreak and almost eliminate the infection in New South Wales by mid-May. And more recently, we've got another set of cases and smaller number of clusters. So diversity of the current situation in New South Wales as far as genomic diversity is concerned is much smaller. So we have essentially small number of extremely similar strains co-circulating in our communities, leading to several epidemiological clusters with distinct epidemiological risk factors and presentations of the disease. It has added significant value to public health. Of course, this is just two examples. Daily Telegraph acknowledged the genomic proof that cases, recent cases in New South Wales started from people crossing the border from Victoria to New South Wales. And this is the first time I've seen word genome used in Daily Telegraph. And then the second example would be investigation of cases originated from a hotel quarantine security guard case. This is an example where epidemiology might be not sufficient to give high confidence inferences about potential sources of infection or transmission pathways. And new technology like genomic technology can help epidemiologists to save their time, increase the confidence of evidence, and support public health investigations. And my last point is about different range of questions that diagnostic technology can assist in answering, and choice of those technologies are very much influenced by these questions. When you look at resolution of testing and surveillance, so clearly laboratory diagnosis that is based on PCR, and PCR targets small proportion of genome, clearly making this rapid diagnostic result. And we initially used genomics to confirm first cases of COVID-19 infection in New South Wales, confirming specificity of PCR detection. But when you think about inferences about lineages, viral evolution over time, virulence of the virus over time, and implications of this understanding to drug design and selection, to design of vaccines, you need a lot more information about viral genome. When you are interested in detecting clusters, transmission pathways, risk factors associated with transmissions, your resolution should be much, much higher, and we need between 70 to 90% of consensus genome recovered with high confidence. And this is what we're doing with next generation sequencing technology at the moment. So this is just a very brief summary of points in a short period of time that I would like to make. And David, over to you.
Thank you, Professor Senchenko. Very interesting, particularly your slide 5 regarding the diversity, and then the 2 waves there. I would encourage everyone, I remind everyone, please put your questions into the Q&A box for our Q&A session at the end. Well, thank you very much, Professor Senchenko. Now we'll move on to Professor Wallach's presentation. I believe, Professor Wallach, you are adhering to what you said to us last week, that you want to adhere to the principles of the anti-PowerPoint movement. Is that correct?
That's correct.
Okay, well then over to you.
Not to criticize anyone who uses PowerPoint. So it's a great pleasure to be here, and thank you for the invitation. My talk will be focused on how to manage the pandemic And I call it a time to stop and think very carefully before we go forward, and especially in light of the previous speaker. Now, the overall goal for whatever approach that's taken, be it vaccine or otherwise, is to develop good herd immunity with minimal morbidity and mortality. And there are two basic approaches that I would divide it into. The one that sort of is represented by the Swedish approach is learning to live with the virus and to coexist, and to really trust your population to do the right thing. And then there's the approach that's been used in Australia, which is largely about suppression, eradication, lockdown, and vaccine. And I'd like to, first of all, look in terms of the advantages and disadvantages of each approach, and to think carefully, as I say, before going forward, and to think about the role of testing in all of this. So if we look at the side of the vaccine approach and the sort of suppression and eradication that's being used in Australia, the obvious advantages is if we could eradicate the virus, it would be an absolutely amazing and wonderful outcome. And certainly it would greatly lower the level of morbidity and mortality in the population. And clearly that's the goal, and I think it's a very socially conscious goal. By using a vaccine approach, one can induce herd immunity very quickly, assuming the vaccine is really truly effective. In light of the last presentation, with all the variations occurring in the virus over time, this may be a hard thing to achieve. The disadvantage of the approach that's being used here, of course, is number one is the huge cost to the economy with job loss that certainly will be coming now once we come off of Job Seeker and Job Keeper. And that cost is enormous also in mental health. The other thing that I'd like to highlight with using a vaccine approach is the selective pressure it puts on the virus to mutate. And I spent many years working in veterinary medicine and seeing, with particularly for infectious bronchitis virus in poultry, we get into an endless cycle of vaccine production, new strain comes along, new vaccine, and it's gone on for 40 or 50 years. We are playing a game with essentially molecular evolution. Now, on the side of living with the virus, the advantages are, number one, in being exposed to live virus in a controlled manner, the immune system will give the full spectrum of the immune response, whereas with the vaccine, it's very specific, usually to the S1 region of the spike protein. The goal in living with the virus model is to flatten the curve, not to try to eradicate, to try to keep the economy going and lower job loss, and to manage and control the pandemic without putting enormous selective pressure on the virus. Of course, the disadvantages are, as we've seen, when control is lost, there are sudden spikes with high morbidity and mortality, and that's the thing that has to be managed. And the other thing, which I would call in a sense an advantage, is it requires people to establish new social norms and to understand that we may not go back to the same type of lifestyle we had before the pandemic. So the question is, on the vaccine side, I think it's pretty clear, and in a way that is the strategy that's been adapted here. But I would like to think about, prior to going down that path, how can we go another approach or use another approach in Australia that again is more of a management approach. And first and foremost, as we know, it's this social change. It's social distancing, washing of hands and masks, etc. But also an approach that I've been taking to develop together with collaborators at Stanford Medical School is to use antibodies actually produced by hens in egg yolk called IgY, which is the chicken equivalent of IgG, to coat the oral and nasal pharynx to sequester the virus and prevent it from being able to get down lower into the respiratory and digestive tract, and to greatly lower transmission. So it's the whole thing is about transmission lowering or transmission blocking, so that people, rather than going through a very high infective dose that causes severe disease, goes through a very low immunity-inducing dose. Accompanied by this would require testing, 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 as the WHO said early on. First of all, to continue the PCR testing and the monitoring of the different strains that was described beautifully in the previous talk, and introducing the new tests and point-of-care tests being developed to test for the presence of antibody and antigen, to be able to know, first of all, in a rapid way, if a person is infected in real time, and to be able to see what's the immune status. Understanding fully well that immunity is not going to be perfect, but in the end, immunity is what we need to develop. And there are a number of companies, including Abbott, Roche, and SureScreen, now in Australia, developing these tests. And I personally believe they can be used very effectively to constantly monitor the population and stratify the population in order to create a situation where you sort of can have an immunity passport and be able to tell who's gone through an infection, who's likely to be immune against reinfection, and how do things develop over time, and to learn from that. As I said before, the approach of vaccination can be incorporated into this. However, once again, I'd use it only very strategically for perhaps certain portions of the population. And of course, we have the vulnerable population that have to be particularly well protected, that are unlikely to mount an effective immune response, even with vaccination or exposure to live virus. Now, I'll just end by saying, what is the goal of herd immunity, as we're hearing from WHO and others, is that 60 to 70% of the population develop this herd immunity. The WHO recently announced that they estimate it to currently be at about 10%. I would argue, and this is also based on T-cell immunity and perhaps other forms of innate immunity, that I believe the immunity level is much higher than that. In Stockholm, they found T-cell immune responses in 30% of the population. And it's very difficult now to assess immunity in people that were exposed to the virus several months ago in any case. So it may be difficult to actually measure the level of herd immunity, something we'll be observing over time. Finally, taking together the economic impact of all this, and to go back to the original question I posed of thinking about which direction to take, I would think very carefully at this point about the approach we take of not jumping on vaccines quickly because of the potential of viral mutation leading to a situation that's worse than what we started with. And certainly to implement all the measures we can for lowering transmission. We've already seen great benefits in terms of the influenza incidents this year. And I, for one, am a personal believer in learning to live with the virus. With that, I thank you.
Thank you, Professor Wallach. No doubt, after COVID, it is the end of the world as we know it, and life's going to be a little bit different afterwards. Thank you for sharing your insights. We'll now move on to our third and final speaker for the morning, Professor McLaws. I hand you the floor. Over to you.
Thank you very much. I believe you can now see my slides, correct?
We can, yes. It's not in presentation mode, but we can see your screen.
There we go.
Now, again, like earlier this morning, we're seeing your prep slides leading to your...
Apologies.
There you go. All good.
All right. Thank you very much for the invitation. I'm going to give an overview of where we are at the moment globally, then a quick overview of where we are in Australia and some of the challenges that pathology need to consider. Okay, just to remind everybody, you may not realize it, but of course, on the 20th of January, China told the world they had a problem and that they confirmed that there was human-to-human transmission. Most importantly, January 30th, a FEAC was announced. A FEAC, a public health emergency of international concern, is more important to be called rather than a pandemic. A pandemic basically says that it's crossed 2 continents and outside just one jurisdiction of WHO. And the FEAC requires all member countries legally, sadly there's actually no recourse legally, but legally to then start preparing. So it's actually the January the 30th that's more important than actually when WHO calls it a pandemic. So where are we? So this is basically an overview of last week to this week. And what we've found is 37 million cases. Like Australia, the majority of the cases by proportion, the largest worldwide is 25 to 39. In Australia, it's the 20 to 39-year-olds. We understand why that is. They're highly mobile socially. They're mobile in Australia to try to get enough jobs to put food on the table. They do a lot of part-time work. That puts them at risk of meeting a lot of people, potentially acquiring it and therefore transmitting it. 91% of new cases are in the region called the Americas and Europe and Southeast Asia. We are actually in what's called WIPRO area, which I'll show you in a moment. 60% of the new cases in countries are led by India, the US, Brazil, Argentina, and France. And sadly, there's over 1 million deaths. 55%, so over a half, are in the Americas region. A third, sorry, less than a third, but less than a quarter actually, are in the European area. And of course, sadly, the 65-year-olds overrepresent the deaths. So these are the regions, and the East Mediterranean region is led by Iraq, Iran, Morocco, and Lebanon. And Jordan has, in the last week, doubled its number, and it's at the peak from its last 5-week numbers. So watch this space. The Americas, led by the US, Brazil, Argentina, Colombia, Mexico, and then Peru. The Africas down here in the lower left-hand corner is led by South Africa, Ethiopia, and then the Uganda, Nigeria. South Africa has had an increase of 29% in its mortality. So it has a real battle. The final area in this slide down here is the Southeastern Asian area. That has reported 30% more new cases globally. It represents not quite a third of all global cases in just the last week. So there's an issue going on in Southeast Asia. In the European areas, it's led by the Russian Federation, the UK, Spain, and Israel. And their numbers have rapidly increased in the last week. Russia is the first in Europe and the 6th globally for numbers. And finally, the WIPRO area, the Western Pacific region, where we are. How are we doing? Well, the Philippines, Japan, and Malaysia have the highest increase in numbers in the last week, with Malaysia reporting 119% increase. So we have the first wave continues for Indonesia, Iraq, and Myanmar. They haven't finished their first wave. Second wave we're seeing in the UK, in France, and the EU. Some will say, of course, that that is because France has increased its surveillance, but the numbers are suggesting it's not just the occasional spike, which better surveillance would suggest. This is an increase. It's already representing 56% of the cases that it had in its first wave. So watch France very carefully. So how is Australia going? So we know sadly that 93% of the second wave has been experienced by Victorians, and they've been amazingly brave with their lockdowns and cooperated remarkably well. So at the moment we have just over 27,000 cases. So I developed a traffic light system of a green, less than 5 cases per day, an amber, which is somewhere between a total case over 14 days of 60 to 99, and then once you reach over 100 cases over 14 days, or that is over 7 cases on average, you've reached the red area. And that's the area, unless you really bring in the contact tracers and public health initiatives, you're going to have problems getting it under control. In New South Wales, it's taken us 2 months to get back to the green zone, but we have, after being seeded by some cases in Victoria. Victoria never really got into the green zone ever, and this represents Victoria. We can see here on the left-hand side the R. Now, the reproductive number is usually set with a 7, but we have better information now that the serial interval, that is when you start to become infectious to others, is day 3, 4, or 5 after exposure. So I've set it at the median at 4. So you can see during the red area, it oscillates. So it's not the best indicator. It's usually a better indicator, a little bit post-fact. I then did an average, this middle one, over 14 days accumulative average, and looked at how it grew. And you could see it climbing. I then looked at the change between those rolling case numbers, and that gave me a better indication of what was happening. But eventually I did a ratio and found that this hard line here gave a much better indication. See the uptick here? It's subtle, but it also relates to that increase in the amber zone of 60 to 99 cases. Now, this is for a large city or state. I've noticed that the federal government has quite rightly adjusted this for according to population. But I'm hoping that eventually we won't have borders. We'll stop the closing of states and large cities. We'll all agree on some sort of traffic light system. The Danish system, forget about it. It's very blunt. And in fact, during the height of the Victorian second wave, it indicated that Australia was safe, but didn't indicate where it was definitely not safe. It's really only something that's used in Europe for a hint about where to travel, but their tolerance for risk is much greater than ours. So this can be adapted, my version can be adapted for, I'm hoping, for small clusters where we have a national contact tracing group that swoop with all of the human resources we have around Australia where it's needed and never have to close the borders again. So where are the challenges? So some of the challenges will be asymptomatic levels. I was part of a group led by the lovely Paul Glasio from Bond University, and we had globally looked at asymptomatic levels. Some commentators were talking at 40, 44, 50% asymptomatics, but that was because they hadn't excluded the Diamond Princess that failed to follow up their asymptomatics. So this picture here on the left-hand side suggests that there was only ever 2 ideas, the initial asymptomatics and the symptomatics. WHO then explained to the world that in fact there are pre-symptomatics, and then there are those, and they didn't know exactly what the proportion was, of true asymptomatics. So we excluded any paper, any study that hadn't followed up their pre-symptomatics to be for at least 7 days. And this is what we found on the right-hand side. We've separated it by age care and non-age care, and found that age care, the asymptomatics is about 20%. Non-age care is about 16. They cross over, the confidence intervals cross over, suggesting there's really no significant difference. Too much it could be due to the fact that we have only small studies at the moment, but we think it's around 17%, at the upper limit 20%. So you have at least, let's say, somewhere between 14 and 20% asymptomatics out there in the community. Do they drive the pandemic? So we then had a look at the asymptomatics versus the symptomatics, and how well they caused secondary infections. You can see some of the numbers are quite small in the asymptomatics, small sample sizes, but found that asymptomatics, the risk of secondary infections in another cluster or families was 0.58 compared to symptomatics. In other words, there's about a 42% reduction in less likely to cause a further spread. So they are important, but not as important as those with symptoms. So knowing that and doing only symptomatic testing, where are we up to? How are we going? Well, New South Wales, this is a couple of graphs that I've looked at by a number of tests weekly that I looked at. So I've done it by weeks, and I've looked at the positivity rate. And as you can see on the left-hand side, New South Wales has increased its testing from May until June, and steadily increased it. And then it has plateaued out, but so has the seroprevalence has plateaued out, and they've waited for that decline in testing until the seroprevalence declined. However, both New South Wales and Victoria, and also South Australia, has reduced its numbers of testing, which is a concern. So the Victorian one on the right-hand side shows that there was a steep increase in June. I looked at the numbers and predicted back on the 18th of June, when they had a total of 102 cases that were entering a red zone, and their numbers of testing increased dramatically. There was a distance between the testing and, of course, the seroprevalence reporting, that, of course, we all know was due to a huge impost on pathology. And you can see that distance, that and of course, it has a lot to do with the time it takes people to get tested, about 3 days, which is a bit difficult with this particular disease. It's unlike SARS-CoV-1, where its serial interval was nothing like this one, and that's probably the reason that SARS-CoV-1 declined so rapidly by June. But this one has this serial interval that's early and problematic. But nevertheless, Victoria has declined in testing, and I think declined in testing too soon could be due to the fact that the population are getting tired. This is looking at just purely proportion of positivities versus the number of tests. So you can see in New South Wales, their testing and seroprevalence, the more they've been testing, of course, some of the seroprevalence has increased, but they've been very consistent. In Victoria, the seroprevalence it peaked, of course, as the testing peaked, but that suggests to me it's still going up, and that they really do need to continue testing. But the proof is in this one. total weekly testing is on the left-hand side, but it's not adjusted by population density. So I've adjusted it by population density, and we're still seeing that sad decline in testing. So the blue represents Victoria, and they did well in the number of tests that they performed. The red is New South Wales, and of course they performed very well with the seeding of some cases. And South Australia is the light blue, but all of them have declined in numbers by about a third, and it's far too soon to have this decline. So too soon to slow down testing, and to open up borders. We need to roll out more preemptive testing. After making this slide, I had heard that Victoria is sensibly going to test high risk employees such as healthcare workers, carers, and abattoir workers. But we also need, given that we have somewhere between 14 and 20% of cases are asymptomatic, and that they still can cause more cases, although albeit at a lower level than symptomatic cases, we still need to do more testing and more community testing. Now, we do tell people when they are tested to stay at home if they've got symptoms, but given that everybody in Victoria are wearing a mask, I can't see why not. That testing should include asymptomatics, in other words, general populations, particularly in suburbs of hotspotting, and then rolling it out to anybody that wants to get tested, but particularly in the low socioeconomic level suburbs, not to pick on them, but to protect them, because globally, low socioeconomic groups are at greater risk because of crowding, because of what they have to do for work, etc. And this way we'd be able to know exactly where our seroprevalence is heading. So what next? I don't believe we'll have a vaccine rollout at all this year. There are 9 candidates. 80% normally outside of pandemic fail phase 3, but even if they don't fail phase 3, they're still developing their phase 3 trials. They enroll people as in cohorts to make sure that they have the right number of age groupings. We will have take quite some time, at least until the end of this year, for them to be able to do analysis to find out how it's going. Don't expect a high level of vaccine efficacy because this is an unprecedented time. You may get vaccine efficacy of 50, 60%, which could be problematic because then you'll have to work out, do we have to vaccine everybody in Australia, which is unlikely. So we need to have a national approach to managing small cluster outbreaks. I concur to some extent with Michael's assumption that there's some way of living with this, but as an epidemiologist, I believe that we live with as lower risk as possible, and less than 5 cases on average over 14 days is low, and it's very manageable. New South Wales has had 3 decades of investment in contact tracing, and they have proven that with training of public health officers and contact tracing at its peak, that it can cope with less than 5 cases or even a bit more. You don't want it a bit more because then it increases the risk to the community, but nevertheless, small clusters putting out those embers of bushfires so that the community are not suffering from lockdowns all the time. I'd like to see a travel and work bubble with our Wipro neighbours in Asia. But how would you identify the correct ones? Well, they need to be having the same philosophy of testing regime per million, infection rates per million, and outbreak management. Their leaders need to match our leaders for the mentality that they have. So China, Taiwan, Hong Kong, potentially Japan, but they're going to have to increase their testing rates. Of course, our close neighbour, much loved New Zealand. In 2021, I still don't think that we'll have a general population rollout. Hopefully we'll have something for the frontline healthcare workers. I hope we don't see a third wave, but particularly if we pounce nationally on small clusters, we may not get third wave in Australia. It's far too late for the US, the UK, and the EU to use the 5 public health approaches of distancing, masking, testing, isolation, and contact tracing. They've left it far too late. Their population haven't been trained as well as ours, and I think we need to congratulate ourselves and our leaders for doing a wonderful job. And David, that's all I have. Thank you very much. And sorry if I've gone over time.
Not at all. Thank you very much for sharing your views. Great overview of the global response and with specific overview of the local responses. So thank you again, Professor McLaws. We are a little over time, but nonetheless, there are a few questions on the Q&A, and I do want to start with one for all of you. I do, and the question is: should we be using? So just a second. Here we are. Yeah. Should we be using testing, rapid testing widely as a way of enable the reopening of the economy?
Well, I'll start from a WHO perspective. WHO, of course, I'm not representing WHO in this opinion, but they are suggesting and supporting rapid testing for countries with high prevalence. And high for us is super high, 5%, 10%. We're nothing like that. I think the last estimate by a group that looked at elective surgery was 0.28%. And of course, this rapid testing is for symptomatic, not asymptomatics. So I can't see that rapid testing on the population with such small prevalence, seroprevalence, will work in Australia, but it's probably got a great place in testing healthcare workers. We don't want them to go on furlough all the time. So that sort of thing in residential aged care facilities. But I'll let the others.
Yeah, I'll just add to that, and I think I really appreciate your presentation, Mary. Part of this is also to learn, because this won't be our last pandemic. And I think the importance of testing, apart from the immediate importance, is the long-term importance of understanding the epidemiology and molecular evolution of this virus and the immune response over time in different subpopulations, I think is crucial. We should think not only of what's happening now, but what's going to happen in the future. We did not, as a global community, manage this pandemic well at all. We're unprepared. And this is an opportunity to learn and prepare for the next one. We may have coronaviruses coming through us now quite frequently. So I think that's the real value in testing, is to learn and with an open mind to things that may be surprising.
Thank you. Professor Sinchenko, do you have a view on this matter at all?
Well, yeah, I agree with Mary-Louise and Michael. And Michael, I think, touched very critical point, essentially, is that we've got this, pandemic quickly recognized and managed, at least in some countries like Australia, because of rapid developments and advancements in technology. Yes, it could be another coronavirus, or there are thousands of other viruses, bacteria, fungi, etc., that await their turn. So our capability to identify and recognize pathogens is unprecedented. And given right circumstances, we can face regular pandemics, so to speak, of significant scale. So clearly we need to be prepared and manage risks better in the future. As a clinical microbiologist, I prefer tests that are accurate. And there is a trade-off, unavoidable trade-off between timeliness and accuracy. Rapid tests will bring risks that Mary-Lee is implied to, of missing cases that can still be infectious.
Okay.
So I have significant reservations about rapid testing.
Okay, so maybe more information in this regard.
Yeah.
One thing I recognise you mentioned, Professor McClaws, is that we should be proud of our leaders for the way Australia's responded. I'll share a short anecdote. Recently speaking to an old colleague of mine who's from Mumbai, who was saying to me, Australia is a great example, and I'm lucky to be in a country that was concerned about 400 cases per day, where he told me his building the day before had 400 cases. So the question here is, how does Australia's response to COVID-19 testing compare to other countries? You kind of mentioned it a bit, but I'd like to ask that to all of you. I'll start with you, Professor McClaws.
Well, look, I think Australia, along with New Zealand, is a real poster country for its leadership. I mean, as an epidemiologist with some experience with SARS, I would have closed the borders as soon as I heard about China, because I understand the Chinese are highly mobile, sociable people that move around the world, and you don't choose which country you're going to close the border to. So we have made issues and errors, but my goodness, our leaders are remarkable in their following of science and their care for their population. I also think that one needs to commend Australians. We are a multicultural nation that when you land here, you become a wonderful citizen, and we are peaceful. The protests are rare in Australia. They're very disturbing, but rare. And the Australian public need to be commended often, very often, to remind them how well they've done to cooperate, and particularly Victoria, where they're going through a really hard time. I do think that the government that are providing some support for people who are being tested to be able to stay at home has made a big difference to our epidemic. I do think as in long-term thinking, we need to start thinking regionally. We need to start in looking to our neighbours on how they do things as well, and how they found what worked, what didn't work, so that we can learn, do rapid learning as we go. And finally, I think that we are science driven, which is commendable. When you compare Sweden, so my blood pressure goes up a touch when we're compared, or other countries are compared with Sweden, because they've got 69,000 cases. That's 9,500 per million, and they've got deaths, 582 deaths per million. And in Australia, we've got 35 deaths per million. Now, the one thing that Singapore does, and I'll just finish to give everybody else a chance, but what Singapore does, which we don't do, that we could improve, is anyone over 45 years of age with one comorbidity gets admitted to hospital immediately, regardless of whether they've got what's called mild, which I detest that adjective, because those that have suffered it will tell you they didn't think it was mild much. So I like to call them non-hospitalized COVID. So any 45-year-old that's supposedly would have non-hospitalized COVID, if they've got a comorbidity, they go into hospital, and Singapore's been able to keep their death rate down. So I think that's one thing that we could do better. And of course, move all residents out of aged care into hospital as well, for many reasons. But on the whole, you have to be proud of Australia and New Zealand, our neighbour.
Fantastic. Anything else from our other speakers?
I'll just add to that, and I agree with that. This is an amazing opportunity Australia has, because it has a population that trusts its government. coming from Israel as well, there was a breakdown of trust, and that's caused, I think, the huge social problem there. Here, there's social trust and social responsibility, and it's an opportunity, a great opportunity to take on some risks, as Mary rightly said, be it by giving these different codes or through other means, immune passports, to bring the population forward together towards the day that we open the borders, certainly internally and then externally, control the disease, not jump into vaccines that are risky, work with the WHO, and learn to trust each other so that we get through this together without fear and panic.
Wise words. Professor Sinchenko, final word from you.
Well, not much to add. It has been very balanced reflection. I would just one thing to add, David. The role and quality of Australian healthcare system and frontline workers that really delivered this excellent service to the community in many different means, and this including in healthcare, in hospitals, in ICU settings, etc. So I think investment in healthcare that Australia has made as a country in several decades has paid off. But this, and potentially because of more balanced approach, we might have more kind of less unintended consequences. But the issue of unintended consequences of COVID-19 pandemic on other diseases, communicable and non-communicable, deserves special attention as well. And I think it's time to look into these issues as well. Thanks.
I would just like to add a thank you to all the pathologists who did all the testing. And I think the pathologists did a fantastic job, as we saw. And I think everyone should be congratulated for that.
I think that's a very good way to finish off. I'm cognizant of the fact that the three of you need to get on with your regular day jobs. Yes. So, and I do see that you've been answering some of the questions in the Q&A box, and there's still some outstanding questions. So apologies to those who've put those questions up. We'll endeavour to get some answers to those questions for you from our speakers. But at this point, I'm going to say thank you so much again to our three speakers. It's been wonderful having you join us, making it a special occasion for us. You're more than welcome to stay on for the AGM, but I know you've got to get on with your day jobs. So thank you very much, and have a look out for something coming to you in the mail as a token of our appreciation for your support this morning. So thank you very much.
Thank you.
Thank you.